A nurse is caring for a client who is scheduled for a renal biopsy. Which instruction is most important to include in the pre-procedure teaching? A. You should avoid dairy products the night before. B. You will need to lie on your side during the procedure. C. You should not take aspirin or anticoagulants for several days before the biopsy. D. You can resume regular activity immediately after the test. Answer: C. You should not take aspirin or anticoagulants for several days before the biopsy. Rationale: a renal biopsy involves inserting a needle into the kidney to collect a tissue sample, which carries a risk of bleeding. Therefore, it's essential to stop anticoagulants or blood thinners, for example, aspirin, warfarin, heparin, before the procedure, as they increase bleeding risk. The client lies prone during the biopsy, not on the side. Activity should be restricted post-procedure to reduce the chance of bleeding. Strategy: always assess NCLEX questions for procedure safety priorities. For invasive procedures like biopsies, bleeding is the #1 risk. Thus, anticoagulants are typically withheld. 72. A client with end-stage renal disease develops severe itching. What is the primary cause of this symptom? A. Hyperkalemia. B. Uremia and phosphate crystal deposition. C. Low albumin levels. D. Excessive fluid intake. Answer: B. Uremia and phosphate crystal deposition. Rationale: in ESRD, the accumulation of uremic toxins and high phosphate levels leads to crystal deposits in the skin, causing uremic pruritus, severe itching. This is a very common and distressing symptom. Hyperkalemia causes cardiac issues, not itching. Albumin and fluid intake are not directly related to this specific symptom. Strategy: learn how buildup of waste products affects various body systems in CKD. When you see unexplained itching in a renal patient, think uremia plus phosphate equals pruritus. 73. A client with acute kidney injury is in the diuretic phase. Which assessment finding is most concerning? A. Serum sodium of 133 milligrams per liter. B. Urine output of 3,000 milliliters per day. C. Blood pressure of 92/58 millimeters of mercury. D. Heart rate of 88 Bartleman mercury. Answer: C. Blood pressure of 92/58 millimeters of mercury. Rationale: during the diuretic phase of AKI, the kidneys begin to recover urine output, but are not yet able to concentrate urine effectively, leading to massive fluid and electrolyte losses. This can cause hypovolemia and hypotension, which can lead to shock and decreased perfusion to the kidneys and other organs. Although the increased urine output is expected, the low Bartleman mercury is dangerous. A sodium level of 133 is only mildly low and not the priority. Strategy: in renal conditions, blood pressure is a vital stability indicator. Always flag hypotension as a high priority, especially in fluid loss conditions like diuretic phase AKI. 74. A client with chronic kidney disease reports metallic taste in the mouth and ammonia-smelling breath. What should the nurse suspect? A. Hyperkalemia. B. Hypoglycemia. C. Uremia. D. Metabolic alkalosis. Answer: C. Uremia. Rationale: uremia is a condition seen in advanced renal failure, where nitrogenous waste products like urea build up in the blood. This causes symptoms such as metallic taste, nausea, loss of appetite, and uremic fetor, ammonia-like breath odor. These are classic signs and indicate that dialysis may be needed soon. Hyperkalemia and hypoglycemia don't cause these specific symptoms, and metabolic alkalosis is uncommon in CKD. Strategy: recognize classic signs of toxin accumulation in renal failure. NCLEX often expects you to correlate weird symptoms like odd breath or taste with uremia. 75. The nurse is reviewing a client's morning lab results. BUN 78 milligrams per deciliter, creatinine 6.1 milligrams per deciliter, potassium 6.4 milliequivalents per liter, and bicarbonate 14 milliequivalents per liter. Which action should the nurse take first? A. Administer sodium bicarbonate. B. Call the dialysis nurse immediately. C. Place the client on a cardiac monitor. D. Restrict dietary protein. Answer: C. Place the client on a cardiac monitor. Rationale: the potassium level of 6.4 milliequivalents per liter is critically high and poses an immediate risk of cardiac arrhythmias or arrest. The most urgent intervention is to monitor the heart for any life-threatening changes, for example, peak T waves, wide QRS, or VFib. Calling dialysis and correcting acidosis, bicarbonate, are important, but they take time. Protein restriction addresses long-term control, not acute danger. Strategy: when multiple lab abnormalities are present, always address the life-threatening, time-sensitive risk first. Hyperkalemia equals heart equals monitor now. 76. Which finding in a client undergoing hemodialysis requires immediate attention? A. Muscle cramping. B. Fatigue after dialysis. C. Restlessness and headache. D. Hypotension during treatment. Answer: C. Restlessness and headache. Rationale: restlessness and headache during dialysis may indicate dialysis disequilibrium syndrome, DDS, a rare but dangerous complication where rapid shifts of urea from blood into brain cells causes cerebral edema. Left untreated, this may progress to seizures or coma. Muscle cramps and post-dialysis fatigue are expected. Hypotension is common but manageable. Neurological symptoms are more serious. Strategy: prioritize neurological symptoms in dialysis, especially sudden mental status changes, headache, or restlessness. These may be early signs of brain swelling. 77. A nurse is caring for a client with a Foley catheter who is post-op from kidney stone removal. Which urine characteristic would be most concerning? A. Pink-tinged urine. B. Cloudy urine with foul odor. C. Intermittent small clots. D. Dark amber urine. Answer: B. Cloudy urine with foul odor. Rationale: cloudy, foul-smelling urine is a sign of a urinary tract infection, which is a significant risk post-urologic surgery. Infection in the urinary tract, especially with instrumentation like Foley catheters, can ascend rapidly to the kidneys and lead to urosepsis. Pink-tinged urine or small clots are expected temporarily after surgery. Dark amber urine may indicate dehydration, but is not as serious as infection. Strategy: when prioritizing abnormal urine findings, infection is always the highest priority, especially with catheters in place. 78. A client on hemodialysis complains of nausea, vomiting, and visual disturbances. Which lab result supports uremic encephalopathy? A. Creatinine 1.8 milligrams per deciliter. B. BUN 110 milligrams per deciliter. C. Hemoglobin 11.5 grams per deciliter. D. Potassium 4.7 mequivalents per liter. Answer: B. BUN 110 milligrams per deciliter. Rationale: a BUN level over 100 milligrams per deciliter, combined with neurological symptoms like nausea, confusion, vomiting, and vision changes, points to uremic encephalopathy, a dangerous consequence of severe kidney failure. This condition results from accumulation of nitrogenous waste in the brain. The other labs are within acceptable ranges or slightly elevated, but not critical. Strategy: know that BUN 8 or 100 plus neurosymptoms equals dialysis needed now. Uremic encephalopathy is a neurotoxic emergency caused by accumulated waste. 79. A nurse is caring for a client with nephrotic syndrome. Which diet modification is appropriate? A. Low-fat, high-protein diet. B. High-sodium, low-carb diet. C. Low-protein, low-sodium diet. D. High-potassium, high-calcium diet. Answer: A. Low-fat, high-protein diet. Rationale: in nephrotic syndrome, massive protein is lost in the urine, proteinuria, leading to hypoalbuminemia and edema. A high-protein diet helps restore plasma protein levels, while low-fat helps address the hyperlipidemia that often accompanies nephrotic syndrome. Sodium is often restricted to reduce fluid retention, and potassium-calcium adjustments depend on labs, not diagnosis alone. Strategy: understand why each macronutrient is adjusted in nephrotic syndrome. A protein, to replace losses. A BRAD fat, due to hyperlipidemia. A BRAD download sodium, to manage edema. 80. A client with CKD has a phosphorus level of 6.5 milligrams per deciliter. Which food should the nurse instruct the client to avoid? A. Apples. B. White rice. C. Cheddar cheese. D. Green beans. Answer: C. Cheddar cheese. Rationale: cheese and other dairy products are very high in phosphorus, which must be restricted in CKD to prevent hypocalcemia, secondary hyperparathyroidism, and vascular calcifications. Apples, white rice, and green beans are low in phosphorus and are safe. Phosphorus is often hidden in processed and high-protein foods like cheese, nuts, colas, and meats. Strategy: know phosphorus-rich foods, dairy, nuts, beans, meats, dark colas, and teach clients with CKD to avoid them to prevent complications like bone disease and itching. 81. A client with chronic kidney disease is prescribed a low-potassium diet. Which food selection indicates correct understanding? A. Baked potato. B. Cantaloupe. C. White rice. D. Dried apricots. Answer: C. White rice. Rationale: white rice is low in potassium and is a safe carbohydrate source for clients with CKD. In contrast, baked potatoes, cantaloupe, and dried apricots are all high in potassium, which can be dangerous in renal patients due to the kidney's reduced ability to excrete potassium. High potassium levels can lead to fatal cardiac arrhythmias. Strategy: memorize common high potassium foods: bananas, oranges, potatoes, tomatoes, spinach, melons, beans, dried fruits. Choose low potassium carbs like white rice, apples, and berries when available. 82. A client with CKD has a hematocrit of 25% and reports fatigue and weakness. What is the best nursing action? A. Recommend a high iron diet. B. Prepare to administer epoetin alpha. C. Encourage bed rest. D. Apply oxygen at 2 liters a minute via nasal cannula. Answer B. Prepare to administer epoetin alpha. Rationale. In chronic kidney disease, anemia results primarily from reduced erythropoietin production, not from iron deficiency. Epoetin alpha stimulates red blood cell production in the bone marrow and is the standard treatment for CKD-associated anemia. A high iron diet may help if there's iron deficiency, but the root cause here is hormonal. Oxygen and bed rest may offer temporary symptom relief, but do not treat the underlying issue. Strategy. Focus on treating root causes, not just symptoms. When anemia in CKD is due to lack of erythropoietin, epoetin alpha is the direct solution, not just iron or oxygen. 83. Which assessment finding would cause the nurse to hold a client's scheduled dose of enalapril for hypertension? A. Potassium 5.1 MEq per liter. B. Creatinine 1.5 milligrams per deciliter. C. Blood pressure 92/60 millimeters of mercury. D. Pulse 78 BPM. Answer C. Blood pressure 92/60 millimeters of mercury. Rationale. Enalapril is an ACE inhibitor that lowers blood pressure. If the client's BP is already low, giving the medication could lead to symptomatic hypotension or even shock. A creatinine of 1.5 is borderline, but not critical. A potassium of 5.1 is slightly elevated, but often expected with ACE inhibitors and monitored closely. The pulse is normal. Strategy. When giving antihypertensives, always check BP before administration. On NCLEX, a BP below 100 systolic is a red flag to hold the drug and notify the provider. 84. A nurse is reviewing a client's lab results and finds a serum bicarbonate level of 16 MEq per liter. What does this indicate? A. Metabolic alkalosis. B. Respiratory alkalosis. C. Metabolic acidosis. D. Respiratory acidosis. Answer C. Metabolic acidosis. Rationale. A low bicarbonate level, 22 MEq, indicates metabolic acidosis, a common complication in CKD due to the inability of the kidneys to excrete hydrogen ions and reabsorb bicarbonate. Metabolic alkalosis would show elevated bicarb over 26. Respiratory conditions affect CO2 levels, not bicarb directly. Strategy. Know your ABG norms. HCO3 minus 22 to 26 MEq per liter. Low, metabolic acidosis high. Metabolic alkalosis. In renal failure, acidosis is expected and needs bicarb replacement or dialysis. 85. A nurse is caring for a client who missed a hemodialysis session and presents with shortness of breath, crackles, and a BP of 180/100 millimeters mercury. What is the priority nursing action? A. Administer loop diuretic. B. Restrict fluids for 24 hours. C. Prepare the client for urgent dialysis. D. Place the client in Trendelenburg position. Answer: C. Prepare the client for urgent dialysis. Rationale: this client is experiencing fluid overload and hypertensive crisis after missing dialysis, with signs of pulmonary edema, crackles, SOB. The definitive treatment is urgent dialysis, which will remove excess fluid and toxins. Loop diuretics may not be effective if the kidneys are non-functional. Trendelenburg worsens breathing. Fluid restriction helps prevent worsening but does not treat the current crisis. Strategy: when a dialysis-dependent client misses treatment and presents with overload, the answer is nearly always dialyze now. NCLEX will test your ability to act decisively in emergencies. 86. A client with CKD has a phosphorus level of 5.9 milligrams per deciliter. What is the best food to recommend for lunch? A. Macaroni and cheese. B. Grilled salmon with broccoli. C. Turkey sandwich with white bread. D. Chocolate pudding. Answer: C. Turkey sandwich with white bread. Rationale: a turkey sandwich on white bread is a low-phosphorus meal that provides protein while avoiding dairy, dark sodas, or whole grains, all high in phosphorus. Mac and cheese and pudding are dairy-based, high-phosphate choices. Fish, especially salmon, contains phosphorus, and broccoli has moderate levels. Strategy: in CKD diets, avoid phosphorus-rich foods, dairy, beans, fish, whole grains, cola, chocolate. Opt for low-phosphorus starches, white bread, pasta, and moderate protein like poultry. 87. A client is admitted with nephritic syndrome. Which assessment finding does the nurse expect? A. Frothy urine and severe proteinuria. B. Cola-colored urine and periorbital edema. C. Urine positive for ketones and glucose. D. Cloudy urine with foul odor and dysuria. Answer: B. Cola-colored urine and periorbital edema. Rationale: nephritic syndrome typically presents with hematuria, causing dark or cola-colored urine, mild proteinuria, and edema, especially around the eyes, periorbital edema. Nephrotic syndrome is associated with frothy urine and massive protein loss. Ketones and glucose suggest diabetes, and dysuria with foul odor suggests infection. Strategy: distinguish between nephritic versus nephrotic. Nephritic equals blood in urine plus some protein. Nephrotic equals massive protein plus frothy urine plus hyperlipidemia. 88. Which lab value should the nurse monitor closely in a client receiving calcium carbonate for CKD? A. Potassium. B. Hematocrit. C. Phosphorus. D. Glucose. Answer: C. Phosphorus. Rationale: calcium carbonate is a phosphate binder used in CKD to reduce serum phosphorus levels by binding with phosphate in the gut. Therefore, monitoring phosphorus levels evaluates the effectiveness of the therapy. Potassium and glucose are unrelated. Hematocrit is monitored in anemia, not phosphorus control. Strategy: always connect lab monitoring to drug function. For phosphate binders, phosphorus is the target lab. 89. A nurse is assessing a newly created AV fistula in a client's left arm. Which finding requires immediate action? A. Audible bruit and palpable thrill. B. Redness and tenderness at the site. C. Mild swelling around the site. D. Bruising near the insertion area. Answer: B. Redness and tenderness at the site. Rationale: redness and tenderness at a fistula site can indicate infection, which is a serious complication that can lead to sepsis or fistula failure. A bruit and thrill are expected and confirm blood flow. Mild swelling or bruising is common immediately post-op, but should be monitored. Strategy: prioritize infection signs at vascular access sites. For NCLEX, pain, redness, fever, and warmth at the site require immediate attention. 90. A nurse is teaching a client with CKD about preventing osteodystrophy. Which statement indicates understanding? A. I will take my phosphate binder with meals. B. I will eat more dairy to strengthen my bones. C. I will take my iron pill with my calcium tablet. D. I will exercise vigorously every day. Answer: A. I will take my phosphate binder with meals. Rationale: renal osteodystrophy occurs due to imbalanced calcium and phosphate. Taking phosphate binders with meals prevents phosphate absorption, helping prevent hypocalcemia and bone demineralization. Dairy is high in phosphate and can worsen the condition. Iron and calcium compete for absorption and should not be taken together. Vigorous exercise is not the first-line prevention. Strategy: in CKD, bone protection equals control phosphate plus supplement calcium plus vitamin D. Teaching points focus on timing meds with food and avoiding phosphate-rich foods.